Hello and welcome back to the Advancing Healthcare Innovation Show. I am your host, Michael Stamatinos, and if you're new to us, it's great to have you here. We're really excited about having some just incredible conversations with real leaders that are painstakingly reshaping the future of healthcare. And we're passionate about a few different areas. We're passionate about access, we're passionate about leadership, we're passionate about innovation and innovation adoption. And if it's your first time tuning in, let me just tell you a little bit about what we are doing here. So we're focused on bringing real stories of innovation to life, and not just sharing the wins. It's really highlighting people that are truly innovating within our space and giving them the opportunity and the platform to share their story with our community and ultimately with the world. Now, we've got an amazing action-packed year. We've got a lot of incredible speakers that have the opportunity to come onto the show. And if you hadn't had the chance to check out any historical interviews, wherever you are, however you're consuming this, if you're watching it, just hit the subscribe button now so that any new interviews go directly to you and you're informed about what we're doing. So our field that's constantly evolving, it's shaping, it's moving, it's shifting, and it's crucial to have leaders that can envision a future brighter and embrace innovation and address, a lot of these pressing challenges. We have no shortage of these pressing challenges, but you know what? That just means that there's a great opportunity to make something happen and make things better. Our next guest on the show he's actually one of these leaders, and we're honored to have and introduce Marcus Bost. Marcus is the Chief Innovation Officer at ETSU, East Tennessee State University Health. So he's leading transformation for one of the most mission-driven academic health systems in the country. I mean, they're anchoring innovation in the lived realities of the communities in which ETSU serves. And Marcus is pioneering a future where innovation isn't necessarily reserved for the coasts or confined to startups. I mean, it's born out of necessity, and it's meant to be built to last. I mean, Marcus isn't really one of those that's chasing fads. He's architecting systems. He's been architecting systems at a time where essentially innovation, the buzzword innovation, it can feel a lot like this hollow buzzword. Marcus brings substance, and what he's doing at ETSU, it's really profound. Not to mention it's sort of an overlooked force that's in the Appalachian sort of part of the world. They've got more than 30 clinical sites, more than 250 providers. I mean, his expertise is around having, sort of deep integrations within systems, and he's a Six Sigma black belt. So Marcus has got a pretty good track record of implementing data-driven processes, revolutionizing sort of care delivery models, and just driving efficiencies. So his passion for innovation really shines, bringing cutting-edge technologies with a lot of these strategic goals while making stuff happen. And today we'll get a chance to pick his brain a little bit about, some of the things that he's done over the course of his career, and also some of the things that he's looking forward to in the future. So Marcus, welcome to the show. It's great to see you.
Michael, hey, I appreciate the time and the introduction. That was very flattering. Thank you very much. I appreciate that.
It's my pleasure.
Huge fan of the show. I've watched several of your episodes. Really like the one with Dr. Berkowitz, and had the opportunity to work, I guess, alongside him as a customer at one of his ventures he was involved
Yes.
in. So happy to be in some great company. So thank you for the
Oh,
invite, sir.
that's amazing. I'm so glad that you get a chance to talk to Lyle. He's incredible, forward thinking. Before we kind of dive in and unpack, your role at ETSU, take us back. What was one early experience growing up that sort of still shapes how you lead today?
Yeah. I've thought about this some. I would give credit for this one to my father. So you have to look at my dad. He was career military, Air Force, and I would put this one under the I guess the umbrella of being brave. So dad always had the ability to boil things down to the least common denominator, if you will. And one of the things he told me was, you know, you've seen bad, and this isn't it. And what he meant by that is you survived other things much worse. So
Mm,
be brave, move forward, ask the questions that sometimes don't want to be asked, and then
mm.
look to take those answers and those responses and build upon it and try to make something better. So yeah, not quite fatalistic. Born and raised in Appalachia or Appalachia, depending on which line of the Mason Dixon you're on. But just being brave and being able to move forward because sometimes things are hard, and the trophy doesn't go to the person who wins the quickest, but the person who has the perseverance to move forward. So that has kind of been my mantra going through my career. So yeah, it's been a fun ride. I got the opportunity to work with a lot of great people, a lot of great organizations. Started actually at United Parcel Service, UPS, along with so many others. Humping boxes and loading package cars and moved in to what they called the technical support group. And I looked the other day, and they still call it that. So amazingly enough, and the reason why I bring that up, drawing upon kind of their path, if I may, and then trying to compare and contrast that to healthcare. Um, so when I first got to UPS, they were all on paper. I remember the drivers out in the rain, and you would have to scribble your signature on it.
Yeah.
And the tracking wasn't something they had back then. And luckily, I got to be there as they made the transition. So I got to witness as they deployed the first DIAD boards, data information acquisition devices, I think is the acronym. So I got to be there when they left paper, went that direction. And what's the parallel to healthcare? Well, I've drawn it as this, being able to watch what they've done. So they moved to an electronic format, and
Hmm.
then they put in analytics and data analysis to kind of look for what could they be doing better.
Right.
They always build themselves as the tightest ship in the shipping business, and then they went to the electronic format, was able to pull out and tease the data out of it. And one of the big things that strikes me that they found is left-hand turns were bad. Well, what do I mean by that? Well, they found out that left-hand turns do several things that aren't what are what they want to be doing. One, it wastes time as you're setting at traffic lights. Two, it wastes fuel. Three, because they're setting there, they're polluting the environment. And four, they had a greater chance of accidents as they're making the left-hand turn.
That's right.
So they started designing their routes so no left-hand turn. So you would make a series of rights and get back to where you would be made, but making that left-hand turn. So you deliver in a right-hand pattern, go across the street where you're going to make a left-hand turn, and no left-hand turn, and you're back to where you wanted to be. So drawing upon that, looking at healthcare, UPS went electronic long before 2006 when we all started, on this path. Um, I've been looking for what are the no left-hand turns in healthcare.
Mm.
So we kind of
I
followed
love
the
that.
same we followed the same path. We went from paper, started looking at moving to electronic format with meaningful use and the money that was pumped in 2008, 2009. And now have a treasure trove of data. And we've been gathering it and looking at what we can doing better. I think where we've struggled is having the courage, back to what I talked about before, having the courage to innovate internally and being able to take those learnings and find out what are the no left-hand turns in healthcare. Um, Not that we have not found some, however the right words are for that. There've been a few, but not as many as I thought we would have after being electronic after all these years. So that's kind of been where I've positioned myself, trying to push that envelope, ask the questions that are sometimes uncomfortable to try to help us innovate from the inside. Um, and that's kind of teeing up everything I've done. That's kind of the background of
It's
how
it,
how I got to where I'm at today.
yeah, you mentioned how your dad was a career military guy, so I'm thinking about tours of duty, and you've had a few different tours of duty throughout your career, and environments which you're under a lot of pressure, and you have to be precise. What what lessons from those chapters are sort of inherently still on your speed dial, in your brain today? You mentioned about no left-hand turns, and you're looking out for no left-hand turns in healthcare. What are those lessons that you kind of fall back on, regardless of the environment that you're in?
Yeah. So yes, we're talking about technology, and I like to boil things down like my dad did. So I call that blinky lights. So blinky lights are important. That's where we spend a lot of our time. But at the end of the day, it's all about people. So a lot of what we have to do is managing humans and managing change and being able to move things forward. Probably one of the biggest lessons I have learned in that space is as you're doing the innovation and there are wins and some losses.
Mhm.
I've learned to take the losses unto myself and say, hey, what can we learn? What can we do better? And sheet that up. Now, as far as the wins, I have found that it's most advantageous, certainly in healthcare, to get a team, um, most of the time provider, clinician led, and be quite honest, get them out in front, have them do the talking and take the credit along with the team and a clinician. It gets you more credibility because I'm not an MD and I'm working in healthcare. So, was the blinky light guy? No. So getting yourself a physician that is out there in front to take the wins and to be able to talk about it. Obviously, they're I don't mean to diminish what they're doing. They instrumental. Everything I've been able to accomplish has been part of a team and having great physician leaders. But I like to fashion myself as the kind of the Wizard of Oz behind the curtain. I find it much easier to innovate from behind the curtain where somebody else is getting
Yeah.
credit. Leave me be. Let me do my work. Let me do my innovation, and get you out in front to talk about it and take the credit. And I'll move on to something else. So that's kind of been my lesson learned. I
Mm.
like to operate in that fashion. Be the Wizard of Oz is
Yeah.
has been
Pay
beneficial for
pay no
me.
attention to the man behind the screen, the man behind the curtain. Pay no attention to that man behind the curtain. You know,
Yeah.
it brings you brought up a few different areas that I kind of want to maybe go down and explore because you've worked across a wide range of settings, um, academic health systems, also rural health systems, and ETSU is it's not just a care delivery network. I mean, it's a lifeline for much of Appalachia. What's different and what's harder about driving innovation in a rural sort of academic setting like this one?
Yeah, for I guess for transparency and clarity, my whole healthcare career, I started at Adena Health System in Appalachia, Ohio, also rural lifelines, community, critical access hospitals. Then I moved to Vidant Health, which is rebranded in the last few years to ECU Health, which is also in rural America, not in Appalachia, but on the coast of North Carolina there with large amount of space between humans and clinics and being able to get your specialist out there. And then here at ETSU Health. So I've spent my entire, healthcare career in kind of this rural setting. Certainly the space and the distance is challenging where you have, a catchment area of, 1.3 million people, but they're in an area the size of some states. Um, both
Mm,
in, Southern Ohio with the catchment area of Adena and kind of that swath along the Ohio River where you look
right.
at ECU Health, where it's east of 95 to the water from Virginia, pretty much down to the South Carolina line-ish. A lot of people spread out of a lot of different locations, and the same here in the mountains of Tennessee. So just being innovative in that space is drawn. It looks like a couple different ways.
Yeah.
At Adena, it was a lot to do with transfers to Columbus to the to the academic medical centers and nationwide children's hospitals. So an early project there was using telemedicine when it was still pretty much on the cutting edge. Actually, the funding for that project came from the World Health Organization, and we worked with OHIP and some other ones in the state. And it was a proof of concept. And the idea
Hmm.
there was transfer, no transfer on neonatal patients. And we found out that where we're able to use the technology, be able to triage the infant, and be able to have twice over the number of transfers that were leaving Chillicothe, Ohio, and going to Columbus, which
Mm.
was a big early win in my career. Um, Likewise, also back in Ohio, got to work on being able to do follow-up post-surgical visits. And not to date myself, but this would have been 1999, 2000 timeframe, so a period of
Cool.
time ago. And that one proved out that yes, you could do the same quality of care doing post-surgical follow-up visits, and you didn't have to put, in this case, it was with nursing homes. You didn't have to put the elderly folks in the vehicle and drive them. So that was a win for both the state of Ohio as far as their Medicaid payments, and that was a fun one. Fast forward a few years, looking then at ECU Health, Biden Health. There was and this one falls, you kind of bucket all these out if you want. They kind of fall into telemedicine, process
Right.
improvement, and then business needs. So those first couple were kind of in the proof of concept telemedicine early on. And then you get into process improvement. And the problem that we were having at Vidant at the time had to do with med reconciliation at the rural hospitals, primarily for those patients that were going to be admitted, and more often than not, they were going to be transferred to the academic medical center.
Yeah.
Vidant Health, Pitt Community Hospital there in Greenville, North Carolina, has a distinction of having more referrals in than I think any other hospital in the United States. So a large influx of
Really?
patients
Wow. Okay.
coming into them. So it was utmost important to get the med reconciliation correct. And what we were finding, excuse me, what we were finding is med reconciliation done in the busy emergency departments is best effort. And there were some gaps in the med reconciliation, and that was showing up when the patients were, hitting the academic medical center. So the question then
Mm.
became, well, what's different at the academic medical center than it is at the regional sites? And that came down to having a role, a pharmacy tech that spends the 40 minutes to identify what is the patient, what should the patient be on, what are they actually on, and what else might they be taking. And that can take, up to 40 minutes. The problem was there wasn't enough volume in those regional sites to be able to have a pharmacy tech. So we sat and we
Mm.
thought about it, and a solution came out of it. Or could we use a virtual platform? So that's what we did. Basically, we did it kind of down and dirty with an iPad with a pole, running Cisco WebEx over the top of it. The pharmacy techs that were in the academic medical center would then beam in. There would be a handoff between the nurse and the pharm tech, and they would let them go at it and spend that 40 minutes to be able to do that medication reconciliation. And we had some great outcomes with that, both with the patients getting that extra time and talking about their medications. And then when they were admitted, and the nurse didn't have to do that work. And if they got transferred to the academic medical center, everything was already set up. They were moved over to the correct formulary, and it was a win-win-win on that
Mm.
one. So yeah, a lot of what I find in rural medicine has to do with overcoming the time and the space. Um, Also looking at extending your specialist into the region. So if you
Right.
want to take a cardiac specialist to be able to have office hours in, one of the regional hospitals, that was like 4 hours a day, a drive time. So could you, do those do those specialty visits virtually? And we were able to
Yeah.
deploy that also. So a lot of it sets in that
Mm.
space,
Well, I
if you
mean,
will.
what's interesting is because some say that innovation, you need big budgets, you need a bigger market, but you've proved otherwise. What do you think makes sort of ETSU an ideal ground for testing and deploying? Like, what's next?
Yeah, I mean, a lot of it, a lot of it has to do with, need is the mother of all invention. I think is kind of how
That's
that one
right.
goes. So, just having no choice but to think about things outside of the
Right.
box and being able to move it forward. Um,
Is there
interesting. You
any,
should bring. Yeah, go
I was
ahead.
going to
Sorry,
say,
Michael.
is there any one project that you can kind of think of that you sort of championed, at ETSU that you felt like it was a real breakthrough? And, it'd be nice to know, what made it work? And then
Mhm.
what could have derailed it?
Well, so let's take a look. Let's take a look at one in rural America that was actually a Dina Health System again. This was one that started kind of came out of the need, and it was the ability to get at this time fiber optics to all the regional hospitals. At the time, it was cost prohibitive for the telcos as we crossed different ladders based upon the service area of Adena didn't line up with the telcos service areas. So be able to get fiber optic connectivity where we need it was cost prohibitive. So we started taking a look. I had spent a little time in telecommunications as well. So started taking a look at what would it take for us to build it ourselves. And luckily, about that same time, the FCC was dropping grants for the rural telemedicine, rural health projects. We were able to write a grant in cooperation with Reed Consulting there out of Athens, Ohio, and was able to get an award for several millions of dollars. And long story short, we brought in other health systems that also had the need, primarily to help drive um, the application process, if you will. And we put us all together in a bucket called the Southern Ohio Healthcare Network, which still exists today, and it has grown outside of either Southern Ohio. It links Cleveland and Columbus and Cincinnati. It has moved over into West Virginia, and Pennsylvania, and a little bit into Indiana as well. Um, and some of the cool things with that is, one, by coming together as a consortium, we're able to increase the visibility of it instead of one healthcare system. So
Mm,
very much a collaborative aspect. We were also able to link it into economic development, and it was the first application ever to come from the three different economic development districts in that region of Appalachia, Ohio, to push forward one proposal. And the idea there was if we build fiber to the hospitals that's in, Jackson, Ohio, or Gallipolis, Ohio, wherever that is, as they're passing by, um, you know, industrial complexes, schools, K-12,
right.
industry sites. Could they also throw fiber spurs off and pick those up as they were going by because they're already doing the construction? FCC signed off on that. We're able to get that into the mix as well. So, long story short, so you have the move to electronic health records. Now we're linking multiple different locations again with the data to be able to aggregate it into a central view. The wins for the SOCN and actually for Adena Health System was as the lead entity and the fiduciary agent, they put up the match money for the FCC. And coming off the backside of that, everybody that joined and signed up agreed to give them a certain percentage of their monthly bill so they could recoup that. So it was a money win for them to recoup their money, and they've since recouped that, and they're actually making a little money off of
So
that.
there
So
is a pattern. There's a pattern that's emerging that you've mentioned. So one, which you mentioned earlier about alignment, alignment around, hey, showcasing the wins, but aligning with a clinician to do that. In this new instance, it sounds like, look, hey, we're aligning different health systems that also have the incentive to move forward, yet they're not necessarily competitive. They're complementary. So there's this formula. I'm curious, when you walk into a new challenge, what's like your mental checklist that you go through as a chief innovation officer? Like, what do you size up first? Like, talk me through that. Let's say you get dropped into a new health system, and I'm making this up.
no,
What,
no, keep going.
walk me through. Walk me through your mental checklist and what you're doing.
Yeah, so I do create having moved from organization to organization a couple different times, I create a 90-day plan. Most of the first 90 days, I don't say a whole lot. I listen, ask some questions, seek first to understand. And from that, you'll start to get a feel for the organization and what their challenges are, how that aligns with, my personal skill set, lines against, the experience of what are others doing, and then be able to, after that period, you put together a plan or a roadmap, and you reveal that somewhere after 90 days and start socializing it and see what sticks to the wall. So a lot of it is, being pretty quiet and just asking questions to, again, seek first to understand where am I setting? What are the challenges? What's going on? That's worked pretty well for me, as I've moved from organization to organization.
So you're essentially asking questions to figure out what are those the left turn signals that are popping up.
You got it. You got it.
So you mentioned about your dad being an influence.
Yeah.
Who's shaped your approach to innovation? How do you define innovation? And just, some of those that have shaped you, who were they? Whether they had a title or not.
Yeah. Luckily I came into the CIO role pretty early in my career and was able to get hooked up with the College of Healthcare Information Management Executives, CHIME. And a shout out to them. They have a program, they still have it today, where you can get hooked up with a mentor. One of the ones I got hooked up with was Pete Shelkin. He's since retired, but he was CTO at Ohio State University Medical Center at the time, and being able to pull on some of the things he had learned and the innovation space was very beneficial to me early on. So anybody new coming into this space, I'd recommend finding a good mentor that can help show you the ropes. Coming into healthcare, I came in from, kind of the technology, leaving UPS. I was at, Barrigal Ingelheim for a while and the pharmaceutical manufacturing, and then did a stint in telecommunications, then went into healthcare. So it was a learning curve. It's a different business, if you will,
Mm,
for lots of different reasons. Probably the biggest is, your widget or your product is humans. It's a service industry, so your widget is the providers and the service that they deliver. So that was kind of an anomaly that I experienced versus any other industry, and
mm.
learning how to work in that space. I needed some help learning how to navigate those ropes. So
Yeah.
shout out,
So
shout out to
let's
Pete.
right on, Pete. Thanks for pouring into Marcus here. So just curious if your colleagues were on this show and we asked them, what would they say is sort of your signature Marcus move in a high stakes situation?
Well, that's a good question. Probably the biggest one would be, again, listen, ask questions. At this point, I know you ask, what are your superpowers? At this point, being able to draw upon my experience to know what question to ask when, to be able to start teasing out what are the data points you need to be able to get to where you want to go. I call that process finding the handle. So
Mm,
asking the right questions, getting the data points to be able to find the handle to pick up what we're doing and where we need to go. If you can't find the handle, it's, kind of like trying to wrangle fog. You can't push fog wherever you want to go. If you can package it up and find the handle, then you can pick it up and carry that. It sounds oversimplified, but it has a lot to do with asking the right questions of, some of the same stuff that everybody, who, when, where, and why. What are the business needs? What are we trying to accomplish? Sometimes ideas will pop out of a cake, and you kind of have to ask, well, why? What are we trying to do here? What is the end goal? Well, the end goal in the case of the virtual farm tech was, well, we need to have better outcomes for patient care. Okay, well,
right.
how do we do that? And then you can start backing into it. So, not to use another colloquialism, but start with the end in mind.
That's
What do
right.
we want
Begin
to
with the end in
have?
mind.
What do you want to have in your hand? Is that a Franklin Covey? Is that where that one comes from? Start with the end in mind, I think.
Yeah, Stephen Covey, The Seven
Covey.
Habits of Highly Effective People. So yeah, it's on the top favorites list. I'm looking at one of my on the favorite bookshelf over there. It's on there.
But
That's right.
yeah,
Absolutely.
so yeah, obviously you read and try to absorb, books like that. I think was that one. That one has a red cover. I think I always called that the red cover book. Highly effective habits of, and then there's the other one, Good to Great. That's an interesting read as well.
Yeah.
And then, High Reliable Organizations is another one. Um, and then along the way, I picked up, kind of a Six Sigma Lean background, being able to take a look at things with that perspective, and then project management. I guess I've kind of mushed that all together into, I don't want to call it a religion, but it's a philosophy,
That's
almost a
right.
theology of IT project management. Again, and it helps guide and the questions that I ask.
What's one popular sort of one belief about healthcare innovation that you'll defend, even if it's unpopular?
Yeah, healthcare innovation is hard, but getting people on board is is probably one of the biggest things. So, how does that saying go? If you want to go fast, go alone. If you want to go far, go together. So being able to build that platform, have people that are excited about what you're talking about, getting them engaged in whatever the project is after you find the handle, socializing it, see what sticks to the wall, what pieces do, what pieces don't, and being able to get that team to help you carry it is, I guess, how innovation happens in healthcare. Um,
Do you ever
it
get
is
frustrated? Do you ever get frustrated that things don't move as quickly as you want? And how has your experience allowed you to be okay with, okay, we're moving, we're not moving at the pace that maybe you necessarily want to, but we're moving. How do you deal with that?
That goes back to kind of the first thing I said. I've seen bad, and this isn't it. So this isn't bad. I mean, it's going slow, but it's not bad. And being able to take the little wins as they come, and take solace in that. Sometimes it's just a matter of having the interaction with other humans that keeps me energized and moving forward. So I'm, a half full type of person. We all end up where we're supposed to be. Um, just keep trudging forward, take the little wins. You're going to catch your burrs and you're going to get shot at some. And why did you have this crazy idea? And, we wasted some money. And yes, we did. But look at what we learned. We learned all this great stuff, even if it's, not to do it like that again. Um,
Yeah,
what's the
let's talk
value
about
to
that
that?
because I think oftentimes failure is is looked upon negatively. And the way that you've positioned it is hey, we're learning. We're not failing, we're learning. And we're
Mhm.
learning ideally in a structured environment and one where patient safety is never compromised. Um, and what would you say to someone who's listening right now that's stuck sort of between doing what's safe and doing what's right? What would you say to them?
Yeah, I mean, I don't think, well, not to pigeonhole that, but I don't think those are mutually exclusive. I think you can do safe and right. I think they should be the same thing.
Yeah.
Um, but you are going to have, you're going to have some projects that, and certainly an innovation that don't exactly pan out the way that you wanted to. Um, Probably want,
Any ones that didn't go the way that you
yeah.
wanted to that you're like, oof, a little embarrassing for me to share that you'd be willing to share
There was
and
there
what the
was
learning
one.
was?
Well, there's been several, but probably one of the ones that has probably an interesting silver lining is, we deployed, um, um, and I don't want to, so I won't mention his name again. But this one was one we worked on with somebody I mentioned before, and it was wrapped around, direct to consumer virtual care. And we originally launched with the idea of acquiring new patients. So you direct to consumer virtual care, X percentage of those individuals you're providing care to don't have a
Hmm.
provider. And then out of that percentage, how many of them can you get in to be able to increase your patient, capture from that, almost marketing. Um, that wasn't ended up being where the win was with that project. What we ended up finding with that project, the win had more to do with being able to provide great care to individuals, to keep them out of the emergency department, especially during COVID. We actually,
Yeah.
this health system threw it open free in Eastern North Carolina, where you could use ECU Health Now is what it's called. And it was built on top of MD Live, where Dr. Berkowitz was. To be able to keep people out of the ED. That was a huge win. Another big win was offering it to our employees at no cost. So as part of the benefits package, you got virtual care. This was early on. A lot of folks are doing it now. And the idea there was the visit to do it virtually after hours, 3 o'clock in the morning,
Yeah.
Monday morning, sick child. It did several things. One of which it allowed your employees to get care quicker, so they weren't taking the whole day off to take their child, or if they just had something that they needed seen, instead of waiting 3 days or whatever and them getting sicker and they're off work for a week, they could get seen quickly. So being able to address that very fast. And the last one is, if they have no other choice, it's 3 o'clock in the morning, everything's closed,
Yeah.
hitting the ED, it's $800 ish just to do the triage when you walk in the door, versus the $100 or whatever for that fee. That's kind of a no-brainer as well. And that ended up being where the real ROI was, taking care of our own employees and being able to reduce the load on the emergency departments. So one that didn't work out exactly like we thought it was going to, but ended up being a great silver lining inside of that space. And we were Vidant was one of the early movers in North Carolina in that space. So there wasn't a whole lot of information really wrapped around it. So we got to learn as we go. So a lot of great learnings came out of it. Not not what we thought we were going to get, but we got some
Right.
really cool stuff.
Yeah.
Yeah,
Sometimes you go into that, like you said, with an open mind, and you get the data that you need, and then you continue to move forward, keep moving forward. Like you said,
yeah,
it could always be worse.
yeah.
I,
And
I
no, go
go
ahead.
ahead.
No, I was just going to say part of that is identifying kind of your key performance indicators, monitoring them closely, and start looking for anything that looks different, not what you're expecting, and that's where you can see some of those things starting to emerge. You know, any one of the projects that I do, I want the KPIs on there, and I also, quite honestly, build in an exit strategy. If it's not going the way that you want to, at what point do you say, whoop, nope, and hit the exit and you shut it down and take a look at what you learned and absorb that, digest it, and figure out what you're going to do next time. Or maybe that one is that one that dog just ain't going to hunt, and you shut that one down and you don't
You
come
know,
back to that one.
it's interesting that you say that, because oftentimes we go in thinking it's always going to be successful, and what you're saying is you're not putting the emphasis and focus on priming it to say that it's not going to be successful, but just say, hey, look, things happen. And if things go off the rails, what are we going to do to get them back on the rails? And if things are really, really just uh, unfixable, I think that's very clever to say, when do we pull the chute for us to get out of this plane that's going down? That's really, really clever to
Yeah, it's
think,
got
to even just say that. Yeah.
Yeah, it's kind of the no. That's kind of the. I refer to that one as the no zombie rule. You don't want something walking around half dead. So, don't no zombies. If it's half dead, go ahead and get the heck out of it.
Hmm. All right, so as we kind of wrap up, I want to do two things. One, just give you a
Yeah,
chance to let people know how to get a hold of you, how to keep track of the work that you're doing, ETSU, and just you personally with your own, with your brand. Share that, and then we'll wrap up with a very quick lightning round, a little some unexpected and kind of playful, rapid quick fires.
yeah, sounds great. So again, I'm Marcus Bost. Last name Bost. You can find me on LinkedIn. Search for, I guess, Marcus Bost and any of these companies that I've worked for, and I should pop up pretty quick. Whether that's UPS or Adena Health System or Vidant Health, ECU Health, or of course ETSU Health, where I'm currently at. So yeah, I'm pretty easy to find.
Cool. All right, so let's do a quick lightning round. So let's just say
Yeah,
one rural health myth that you're tired of hearing.
one rural health myth. Um, I say that one has to do with people in rural America not using technology, and specifically, I would go with the elderly folks, your retirees, that sort of age. Um, I think that one is a myth. People want to stand on that our people aren't going to use it. That's not true. And they're older, they're not going to use that. I don't think that one's true either. You got some
Hmm.
pretty savvy, retirees out there. We're getting into the upper end of the boomers and some of the bottom end of the boomers. They've been right here along with Gen X and the rest of us as we've made the transition, and they do online banking too. So online banking and online healthcare isn't that different. So if you trust the online with your money, they'll trust online with their healthcare too.
That's right. And what about favorite non-healthcare innovation of the last decade?
Oh, well, that one's interesting. So I'm going to jump on the bandwagon with everybody else and say AI as just I know it's been talked about, it's in healthcare, but first off, I'd like to point AI has been used in healthcare for quite a period of time. We originally turned up some of the mammography 3D imaging where it looked for different anomalies and was able to start predicting, when somebody should have follow-up care. And that was 2008. So we've had some form of AI in healthcare for quite a period of time. So is it new? Not necessarily new. Is it more powerful? Yeah, it is more powerful. And I look for that space to continue to evolve. Where exactly it's going to go. You got folks like, Bill Gates from even March of this year saying, it's going to help augment and within the healthcare shortage. Possibly, platforms such as MD Live, they've been asking you to upload pictures like strep throat and those sort of things. From what I've heard, what they've shared with me is, they're getting pretty good at looking at an image and being able to decipher, make a diagnosis whether this is strep throat or not. So
Hmm.
that's just strep throat. So where's that going to go? I think it has legs. Kind of excited to see where that goes. I do believe will it go as quick as we think it will? Probably not. It'll probably be 10 years,
Hmm.
20 years, um, just as we get used to it and we're a little scared of it. But I do think it will improve and help healthcare and offload some of the burden of some of the things like, strep throat or whatever.
Cool. And then totally random question. Let's just say we're hosting the Advancing Healthcare Innovation Bowl, and you gotta walk out to a song. What song is your walk-up song if you're getting introduced?
Oh my. So this is getting way into the psyche. So, they say you can learn everything you need to learn about somebody on their phone, whether that's whatever their ringtone is and what pictures they
Mhm.
have on their phone. So personally, I would come out to AC/DC's Back in Black.
There we go. There we go. There you have it, folks. So if you tuned in today and you thought this conversation was exciting, enlightening, entertaining, do us a favor. Like it, share it, please. Would you mind? And for those that have just want to share what they liked about it, go ahead and share with us as well. So, Marcus, pleasure to have you coming on. Always welcome the door for you to come on again and share more meaningful insights. Look forward to our next discussion.
Michael, appreciate your time. Thank you, sir.